Good afternoon, everybody, and welcome. Very nice to see so many people so early in the meeting here already. Brilliant. Um, this is a really great afternoon with a very exciting, interesting topic, I believe. And we look forward to also hearing all of your thoughts on chronic lymphocytic leukemia 2026. What's changed, what still matters, and also learn from each other's experiences. So a big welcome to all of you. I will introduce our speakers in a moment. But before I do so, I just want to start by acknowledging the Blood SA Foundation, who is doing the weekly deep dives in collaboration with the South African Clinical Hematology Society, as well as the South African Society for Stem Cell Transplantation. And a special word of thanks today to AstraZeneca, who has kindly sponsored today's session. This is the deep dive management team, Professor Stelford Berg, Dr. Nicholas Smith, and Mrs. Michaela Brooks. And I also just met Taryn Solomon, who's a new partner on the team. I think Taryn, I guess, will get a photograph on here at some point. So just in terms of the housekeeping, all our sessions are recorded and can be found on the website bloodsa.org.za under resources. So as you can imagine, there are so many videos from the deep dives over the last few years. So for those trainees and fellows who have not been able to, who's joined their training programs late or later than many of these things, please go and have a look. Or if anyone wants to revise anything, such amazing presentations that we've had over the years. And then I want to really ask if you can just take a second quickly and check if you are muted. We often don't recognize that we are unmuted, and then some background conversations can become disturbing or awkward. So please do that. Please add questions to the chat box. Even during the course of the presentations, we'll obviously attend to them at the end, but feel free as you think of something to put them into the chat. Now, CPD points. CPD points will be submitted automatically to the Health Professions Council for each South African registered attendee. So it is important that you are on this meeting with your own registered Zoom link, not as part of a group. And you have to attend for at least an hour, otherwise you automatically are disqualified from your CPD point. Sorry, that's just HPCSA. And also make sure that your MP number is entered correctly. If you are part of another council from another country, just email admin@bloodsa.org.za and they can send you a certificate. If you want to join the mailing list, you can either go to the website, go under resources and subscribe, or you can use this QR code now with your phone. And at the end, you will be asked to give some feedback. Please give it honestly, help the team to make things better. Right, in terms of upcoming events, few advertisements. We are hosting the 2026 Physicians Conference at the Protea Hotel Conference Center in Stellenbosch. It's going to be a really great meeting, awesome speakers, and this is for anybody in internal medicine that want to obviously expand their knowledge, prepare for the exams, but also I want to really encourage the clinical hematologists. We've got so much general medicine that we do as part of our work. This is going to be such a great refresher to make sure we all stay up to date. And part of it, I'll also be there and give a talk at some point. But you can see we've got everything covered from A to Z. So please come and join us. Then the SASMO SASETS conference is taking place from the 7th to the 9th of August at Sandton Convention Center. You can see all the details there. Early bird has already passed. We're now in standard registration. Make sure you don't miss that part, otherwise the late registration fees will be incurred. Of course, we're very excited about the our Hem-Onc conference, which is happening on the 2nd to the 4th of October at Century City. Please have a look at the abstracts. Registration, early bird is open till the 30th of June. Abstracts has opened already. Please, it would be amazing if every unit and every private or university unit can submit something for presentation or for a poster. That'd be so good. And we've really got fantastic support from our trade partners once again. Today we talk about CLL, but next week we're talking about a very complicated topic, idiopathic multicentric Castleman disease. But I want you to notice who is speaking. Prof. Adam Bagg, one of the foremost hematopathologists, actually pathologists in the world, who spent a wonderful sabbatical with us in Cape Town in South Africa, but who's a strong supporter. He's ex-South African, but he's now emeritus professor from the University of Pennsylvania. And if you want to learn a lot while laughing a lot at the same time and hear somebody incredible present, I can assure you, if there were costs to these sessions, I would give your money or promise your money back, but now it's free. So just come. Okay, so the agenda for today, CLL in 2026. What has changed? What still matters? We're going to have Dr. Pieter de Witt give us an overview talk. Then Dr. Zeenat, Moorad, and myself will share some cases that we think are very interesting. And obviously, we would like to learn from all of you. So starting with Dr. Moorad, many of you know her very well. She's not new to the community. She's a clinical hematologist in full-time private practice in Durban. She treats both benign and malignant hematological conditions. And as you can see, she obtained her MBCHB degree summa cum laude from the University of KZN in 2005, and then later joined the Department of Clinical Hematology in 2010 and obtained her fellowship in hematopathology in 2015, MMed in 2018, and subspecialty certificate in 2020. So quite a lot of letters behind her name. And as those who've heard her before know, she's very passionate about education. And but more important than all of this, she's a mum of 3 daughters, family person, a lover of all things chocolate, and a travel enthusiast. And hopefully at some point we will not just be able to listen to sound and see each other on the screen, but also have little things where we can taste the chocolate electronically in the future. And then Zeenat can share that with us. Pieter is a clinical hematologist at Hemalife, based at Netcare Cultural Hospital in Cape Town. Fantastic unit where he's joined by a number of team members. He completed his undergraduate training at Stellenbosch University in 2003, then went to Kimberley Hospital, developed an interest in critical care, did an MRSC in critical care from the University of the Free State, and then later specialist training in internal medicine, again at Stellenbosch University, where he developed his interest in hematology. Qualified as a clinical hematologist from UCT in 2015, and is now in private practice with Hannes Koornhoff, Michael Cass, and Simon Brett. And I want to thank both of you for being with us today and in advance for all the time you've spent in preparing these talks. The good news is that it will be worth your while because you've already got 108 people in the audience that are looking forward to listening to you. So as a start, we're going to start with Pieter, after which Zeenat will share her case and I will then share my case or Zeenat's cases. And then we'll take questions at the end. Pieter, you're welcome to share your screen. Thank you.
Good afternoon, everyone. I hope my screen projects as I intended it to.
Okay.
Yeah, thank you for the kind introduction. And yeah, and thank you for AstraZeneca for supporting this meeting. Yeah, I've given the task to talk about CLL in 2026, what changed, what still matters. This is my opinions. I've been in private practice now for more than 10 years and out of academia for a while. So this is my interpretation of the literature. So yeah, bear with me. So just the usual disclaimer slide. So yeah, what hasn't changed? The epidemiology, it's still the most common adult leukemia in the Western world. Disease of the elderly with a median age of diagnosis at 72 years. There's still male predominance, some familial clustering, and younger patients do have a shorter overall survival compared to age-matched general population. This is steadily changing, and with people with better therapies and people living longer. Now, the biology also didn't change recently. We know it's a mature B-cell neoplasm, co-expression from CD5 and CD23, some light chain restriction. But I think the most important step or important thing that we realized is the B-cell receptor signaling dependence. That's the hallmark of this disease, explains the pathophysiology of this disease, and also help to develop newer therapies that's very active and effective. There's a large genomic heterogeneity amongst patients with CLL, and that drives the clinical course. We know about where in the development, B-cell development, the clone arises from before the somatic hypermutation with the immunoglobulin heavy chain gene being mutated or unmutated, the TP53 disruption, clonal genomic instability, and additional genetic factors, all adversely affecting the prognosis. Diagnosis, the same, that didn't change. Lymphocytosis, typical immunophenotype, and with the main differential being mantle cell lymphoma that needs to be excluded. SLL generally requires some histological confirmation, as FNA and lymph nodes are not quite adequate to make the diagnosis. The staging also didn't change. It's been the same staging system used for many decades, based predominantly on a physical examination with lymph node areas and organomegaly, and some standard laboratory testing in the form of a full blood count in general can stage a patient accurately. And risk stratification has also been known now for a couple of years, and where the immunoglobulin heavy chain mutational status is of utmost importance. It's something that is fixed. It doesn't change over time. So at the time of diagnosis, this can be determined and should prognosticate and guide what you can expect from this patient's clinical course. TP53 aberration is variable. It tends to increase in frequency the longer people live with this disease, and the pressure from treatments and therapies do enhance the TP53 aberrant clone, either detected by the deletion of the short arm of chromosome 17 or on sequencing of the TP53 gene. Also, complex karyotypes also adversely affected. It's not readily available in clinical practice, but it's mentioned in clinical trials as a clear prognostic factor. I included the CLL IPI as a grading system. I think it's important, more not that we use it often in clinical practice, but just the weight assigned to each of these factors, like TP53 mutation weighted the most heavily, unmutated IgHV status, and serum beta-2 microglobulin concentration, which is a surrogate for tumor bulk. Second to that, and then the stage and age is less. Weighted less. So also indications for treatment unchanged. The IWCLL guidelines has been published in 2018. I think it's still relevant for clinical trials, but also clinical practice from a diagnostic point of view, but also when to consider treatment, how to assess response. Indications for treatment: we only treat active disease. We treat symptomatic patients only, and that's evidenced by progressive bone marrow failure, the development of anemia, generally hemoglobin less than 10, due to marrow infiltration, not due to autoimmune phenomena, a low platelet count less than 100, We're all familiar with patients that we follow for many years with platelet counts below 100. So that in itself is, in my opinion, not a indication for treatment, but progressive low platelets in the right context is definitely an indication. Now, massive or progressive or symptomatic splenomegaly or lymphadenopathy, indications for treatment, progressive lymphocytosis, if there's more than 50% increase in a 2-month period or a doubling time of more than 6 months. Note it's above white cell count of 30 or lymphocyte count of 30. So small, not small changes, big changes is important. Autoimmune complications, that's poorly responsive to corticosteroid therapy, which is the first line treatment. And then some more unusual presentation with extranodal involvement like skin, lung, kidney, or spine infiltration. Constitutional symptoms, probably the most common reason for, or one of the more common reasons for treatment is the weight loss of more than 10% of the body weight in the 6-month period, night sweats, fevers, and that difficult one, the fatigue that you ascribe to CLL as an indication for treatment. Now, inactive disease or asymptomatic disease is not an indication for treatment. Now, this has been studied in various trials. I'm going to mention the CLL-12 trial where ibrutinib was used to treat patients with asymptomatic disease but a higher risk of progression. It had no overall survival benefit. It did, however, defer the next line of treatment or prolonged event-free survival, but the risk-benefit ratio is not in favor of treatment, and the most appropriate is still active monitoring and watch and wait. What I think we neglect sometimes is that in this waiting period, especially the patients with higher risk of progression of disease and that might require treatment in the relatively near future, is to do prehabilitation. It's included in the guidelines where you optimize someone's general health. You address their cardiovascular risk factors, you address their obesity, get them as fit as possible so that when they require therapy, they're in the best potential position to require treatment. Also included in this is the vaccinations that these patients require. We talk about optimal treatment for CLL. Now we talk about the symptomatic patient that requires therapy. There's a lot of things to consider. There's lots of patient factors, their age, their fitness, their comorbidities is quite important. Do they have cardiovascular disease or is there renal impairment that might influence your treatment decisions? Patient preference, that is becoming more and more prominent in all the guidelines. It's not the doctor telling the patient this is the treatment that you require. It's a joint decision. You discuss all the different options. The patient decides in the end what risks they are willing to take and how long they want to be on treatment. What are your treatment goals? Is it just a few more years because there's another terminal illness underlying, or is it actually a young patient that you want to keep alive for many decades? And then obviously logistics is always important. Disease considerations is at presentation, do they have bulky disease? Are they high risk of tumor lysis syndrome in somebody with maybe slightly impaired chronic renal failure? Do they have cytopenias already? Because some of the treatments is associated with a higher risk of developing cytopenias. Cytogenetic features very important, TP53 aberrations and the mutational status. Then obviously treatment considerations, especially what other co-medication the patient is using. Do they have medication that influence the cytochrome P450 system, that influence the metabolism of some of these novel therapies? Are they on anticoagulation with the increased bleeding risk that we see with the BTK inhibitors? So when we have a discussion with our patient, I think it is important to include the route of administration. Do they want an all oral therapy? Are they willing to take an IV therapy? Now, oral, there's less pressure on the treatment center. You can treat people that lives far away, but you don't have so much control about adherence. Whereas with IV therapy, you have better control over adherence, but it puts more pressure on the treatment center. It's more costly. There might be infusion-related reactions, and increases the anxiety of the patient due to the intravenous therapy. They experience they're more sick. Then big decision about fixed duration therapy versus treatment until progression or continuous therapy. Now, fixed duration therapy, generally more convenient, is for a limited period of time. People can plan, there's fixed cost, or the cost is more predictable. The toxicity is only for a period of time, and the pressure on developing resistant mutations is less. And there's the hope of a treatment-free period at the end of treatment. Whereas treatment until progression, people need to come for their visits frequently, have their counts checked. There's many of these continuous therapies do have cumulative risk of toxicity over time. The longer you stay on therapy, the higher the incidence of some of the adverse events. Increased cost, obviously, and then there's, due to continuous pressure, there's risk of developing resistant mutations. Now, if you just look at the treatment of CLL, there's lots of different guidelines. The British guidelines, ESMO and NCCN guidelines, things we generally refer to. Most of them moved away completely from chemoimmunotherapy. It's no longer recommended by the Brits, especially due to therapy-related MDS and AML. You might think a 1.5 to 3% risk is relatively low, but it's a devastating consequence. All these novel therapies have improved progression-free survival, and many of them improves overall survival. ESMO guidelines, NCCN, you can consider immunotherapy only if there's no access to targeted therapies and in the good prognostic risk group. Just how the therapies evolved. In 2013, 2014, the BTK inhibitors became available. Ibrutinib was the first in class compared to chemoimmunotherapy. There was various trials done. This is the Alliance 2 trial looking at older patients with untreated CLL, comparing ibrutinib with or without rituximab to bendamustine rituximab. Ibrutinib used as a continuous therapy, and clearly after a prolonged follow-up, markedly improved progression-free survival, and not so clear, but a overall survival benefit. It was relevant in all risk groups, irrespective of IGHV mutational status, TP53 aberrant states. And if you look at the graph on the right, especially major benefit in the TP53 aberrant group, where the presence or absence of the mutation did not really change the outcome, or the drug overcame the adverse prognostic effect of the TP53 aberration. People had a very good progression-free survival. It is all oral. The BTKs is very effective, as we just said, but there's some toxicities associated with this drug. Atrial fibrillation, hypertension, especially with the first generation BTK, ibrutinib. You can see on the graphs on the right, the longer you stay on drug, the higher the incidence of these two, AF and hypertension. So it's a later development and it continues to increase in incidence. Sudden cardiac death and ventricular arrhythmias is something that obviously concerns me quite a bit, and it became quite evident, and patients with cardiovascular disease were later screened and excluded from some of these trials going forward. The risk is significant with ibrutinib, less so, it seems, with acalabrutinib and zanubrutinib. And the class of BTK inhibitors also have antiplatelet effect, so there's risk of bleeding, generally mild bleeding. Second generation is better tolerated, and then there's the new non-covalent BTKs, pirtobrutinib, if there's resistant mutations against the covalent BTKs. These kinase plots just give you the idea. The green dots is what you want, the red dots is what you don't want, and there's a difference in these drugs. Although they're the same class, they've got slightly different adverse events or toxicity profiles. After ibrutinib, the venetoclax came on the market. BCL2 inhibitor was trialed in the CLL14 trial in combination with obinutuzumab. Also untreated patients, elderly or less fit patients. It was a fixed duration therapy over 12 months with 6 cycles of venetoclax obinutuzumab followed by 6 cycles of venetoclax monotherapy, compared to chlorambucil obinutuzumab for 6 cycles and 6 cycles of chlorambucil. So increased comorbidity indexes or decreased creatinine clearance, and the primary endpoint was progression-free survival. Clearly, progression-free survival curves superior in the venetoclax obinutuzumab arm and sustained over a long period of time. It's also improved in the unmutated or the mutational status from the immunoglobulin heavy chain, and as well as the TP53 aberrations. It's probably less so if you just look back at the previous slide on the BTK inhibitors, but still superior. Median PFS statistically significant, more than doubled. But the best outcomes with the good prognostic groups. Overall survival, not quite at 6 years, not almost statistically significant, but not quite. But in the unmutated IGHV group, the 6-year overall survival was clinically significant improvement. So the fixed duration therapies is all oral again. They're very potent drugs. They result in a very quick and deep response, but there's a risk of tumor lysis syndrome. Quite initially was quite a big concern, but it's abrogated by a step-up dosing approach or lead-in phases with anti-CD20 antibodies or BTK inhibitors. They do contribute to cytopenias, which might require dose reductions or GCSF support. And one of the unpleasant side effects might be diarrhea. It's usually combined with the anti-CD20 antibody. The first-line setting is obinutuzumab, and relapse refractory setting reference rituximab, but I think most people believe at this point that obinutuzumab is a more active drug in CLL, and obinutuzumab is frequently used even in the relapse setting in combination with venetoclax. And more recently, the combination of venetoclax and BTK inhibitors. So let's talk about that. So if you've got two very potent, very active drugs in CLL, wouldn't you do better if you combine the two of these drugs and allow it to still give a fixed duration therapy? Venetoclax plus a BTK plus minus CD20 antibody. So that brings me to the Amplified trial that was recently published. It's acalabrutinib, second-generation BTK in combination with venetoclax, with or without obinutuzumab, versus FCR or bendamustine rituximab. It's generally fit patients, so so if the comorbidity index were increased, they were excluded. Not significant cardiovascular disease was excluded. Deletion 17p and TP53 mutations were excluded. So a better risk group, but looking at acalabrutinib with venetoclax, both or without obinutuzumab, and the FCR and BR was investigator's choice. If they randomized 1:1:1. So there was a lead-in phase in the acalabrutinib of at least a month. If they randomized the obinutuzumab group, on the second month they had their weekly obinutuzumab doses, and then from the third cycle onwards, the step-up dosing of venetoclax was added and continued for up until a total of 15 cycles. Primary endpoints were progression-free survival, the depth of response measured by undetectable MRD, and overall survival, and looking predominantly at AV compared to FCR or BR. So PFS markedly improved in the acalabrutinib venetoclax arm with or without obinutuzumab. Best PFS was in the 3-drug combination with highly statistically significant p-values. And if you look at a little bit more detail, especially in the IGHV mutational status, the biggest benefit of the 3-drug combination was with the unmutated IGHV group. But overall, fared better. Look at the depth of response, deepest response with the 3-drug combination. FCR had nice deep responses, even better than acalabrutinib and venetoclax. If you look at overall survival, best outcomes were seen in the acalabrutinib venetoclax arm, less so in the acalabrutinib venetoclax obinutuzumab arm, which is unexpected because the deeper responses were with AVO, and the best progression-free survival was in AVO, but less so in the end with overall survival, but still statistically significant overall survival benefit for AV compared to FC or BR. This was mainly due to adverse events. Grade 3 or more adverse events were the most prominent in the AVO of 3-drug combination, and many of them were due to COVID-related deaths. Many of these trials, unfortunately, were conducted in the COVID era before their access to COVID vaccines, and unfortunately, a big number of deaths. If you look at the tolerability of these drugs, combinations, they do cause significant neutropenia, infections, most common in the acalabrutinib venetoclax obinutuzumab arm, but cardiac events were low. There was pre-existing cardiac disease was excluded. Hemorrhage was mild, BTK inhibitor related, and tumor lysis with this lead-in phase with BTKs before starting the venetoclax or CD20 antibodies abrogated the risk of tumor lysis syndrome. So the major impact, according to me, in the AMPLIFY trial is that acalabrutinib and venetoclax with or without obinutuzumab significantly improved the progression-free survival, also improved overall survival. If you look at acalabrutinib and venetoclax versus the chemoimmunotherapy arm, and the highest undetectable MRD rates were seen with acalabrutinib, venetoclax, and obinutuzumab arm. They also had the longest progression-free survival, but unfortunately, our overall survival was affected by COVID deaths. Safety profile is comparable to previous studies with acalabrutinib, and the acalabrutinib venetoclax arm had the fewest grade 3 or higher adverse events. So actually, a combination that's well tolerated. With the schema, it's courtesy of Al-Sabah to explain the concepts behind fixed duration therapy versus continuous therapy. So fixed duration therapy, if you treat somebody with an effective therapy, venetoclax-based regimen up front, 12 cycles, 15 cycles, 24 cycles, whichever, and get deep responses after that period of time, and patients go off therapy for a couple of years, eventually they will start to progress, where you see the orange square. They might not be symptomatic at the time, and you continue to monitor them until they become symptomatic, and you treat them again with fixed duration therapy for a period of time, and then can come off therapy again. Whereas, and you can see the time on therapy, the blue blocks is relatively small with lots of green bars where the patients are off therapy, where there's no adverse events because of therapy. There's less pressure to develop resistant mutations, and less requirements on healthcare resources. Compared to continuous therapy at the bottom, we use a therapy and maintain the response with patients staying on drug. There's accumulation of side effects. There's pressure for resistant mutations. And when they progress, you lost the BTK inhibitor monotherapy, and you need to switch to a different class of drug, fixed duration therapy at that point, and then off therapy. So if you're just thinking from a financial point of view, it makes a lot more sense to do a fixed duration therapy. And that led to this, I think, very good trial that was conducted and recently presented at the most recent ASH meeting. It's fixed duration versus continuous treatment for chronic CLL. This was an investigator-initiated trial. It's not a pharma company that sponsored this. It was investigator-initiated, phase 3 trial, multi-center international trial in untreated CLL. This is a schema. So it included almost everybody, unless there's a life expectancy less than 6 months or had Richter's transformation. But there was no restriction on age, and included all the high genomic risk factors. Patients were randomized 1:1:1 for either continuous ibrutinib, the current standard at the time of the design of the trial for BTK inhibitor, continuous therapy, compared to venetoclax and obinutuzumab, the standard schedule for 12 cycles, or venetoclax plus ibrutinib for a total of 15 cycles with 3-month lead-in of ibrutinib. And here's the progression-free survival at 3 years. Now, 3 years might be a bit early, but at 3 years, these curves are lying right on top of one another. And the progression-free survival of these 3 regimens are exactly the same. Look at a little bit more detail. Overall survival also not different. The subgroup analyses, I think it's maybe too early to make any conclusions. All did pretty well. I think unfit patients seems to benefit from a more fixed duration therapy than continuous therapy. Look at the bottom bar. And deletion 70p, TP53, it's always the concern group. There's low numbers included in this trial. Not that it was exclusion, it's just fortunately a rare occurrence. The PFS looks a little bit better in the ibrutinib continuous therapy arm. Deep responses or great overall responses, and deep responses seen in the venetoclax obinutuzumab arm with undetectable MRD in peripheral blood and bone marrow, most prominent there. Venetoclax ibrutinib less so, and very little in the ibrutinib arm, or 0, and that is not unexpected. So I want to mention that the post-treatment MRD kinetics appear to be treatment dependent. So I don't know if undertaking MRD is the sole or most important target, but because the kinetics are different depending on the treatment that they receive to achieve that. Generally well tolerated. There were very few serious cardiac events. But it was fixed duration, and at these days, second generation BTKs have better cardiac profiles and will probably be used if you design a trial like this again in future. Infections is a problem with patients with CLL. Symptomatic patients with CLL or patients on treatment have a high propensity of developing an infection. About 70% of all the patients in this cohort developed at least one infection. More than half of these infections were bacterial in nature. That was also the most common cause of death. And the most common COVID-related deaths, again, this trial was trialed in the COVID era, was in the venetoclax obinutuzumab arm. I think we're all aware that the high impact or the higher risk of the anti-CD20 antibodies in the early COVID phase, where they were more virulent strains and had no access to vaccines. So the conclusion of this trial is that patients with previously untreated CLL that a fixed duration treatment with either venetoclax obinutuzumab or venetoclax ibrutinib was at least non-inferior to continuous ibrutinib with regard to investigator-assessed progression-free survival. I think some people stated even stronger than that. But let's have a quick look at the international treatment guidelines. NCCN, ESMO guidelines, probably the two that I refer to most. This is the 2026 NCCN guideline. You see, we used to go for age was important, fitness from go, slow, no go, or fit or unfit. That disappeared from this guideline. There's no age, there's no fitness, and there's no IGHV mutational status in these two groups. Is there a TP53 aberration present or not? That's the only two things to consider according to the NCCN. And on the left is with a TP53 aberration, on the right is without. And if you look closely, they are pretty much the same, the recommendation. So preferred regimens, is it fixed duration? Then you have venetoclax-based regimen with venetoclax obinutuzumab or venetoclax acalabrutinib or obinutuzumab, the two trials that I've discussed quickly. Or if you choose a continuous BTK, use a second generation BTK, acalabrutinib or zanubrutinib. Other recommendations, if it's BCL2 containing, is venetoclax plus ibrutinib. It's not the preferred regimen anymore due to the cardiovascular risk of ibrutinib. That's higher than, and we've got better and safer drugs in the second generation BTK inhibitors. And in certain circumstances, you can use ibrutinib as continuous therapy, high-dose methylprednisolone and CD20 antibodies. And then chemoimmunotherapy is not recommended with the deletion 17p. It should be actually avoided, but can be considered in somebody with CLL without a TP53 aberration, according to the NCCN guidelines. BR, FCR, VenG, G-chlorambucil, or obinutuzumab monotherapy. ESMO guidelines, this is guidance from 2024. The updates, I'm not going into detail, they still have the fit to unfit IGHV mutational status. If you think it's a combination of all these mentioned trials, maybe one preferred to the other, but I think it's important to mention what is oral, what is IV, and needs to be discussed with the patient and take their decision. Just to quickly mention second line and beyond or subsequent therapies, there's just one guideline here for with or without a TP53 mutation. Preferred regimens, venetoclax obinutuzumab or continuous BTK inhibitors, or pirtobrutinib, the non-covalent BTK, and you can read the rest. If there's relapse or refractory disease prior BTK and BCL2 containing, then they consider CAR T-cell therapy or pirtobrutinib, or some of these other options right at the bottom. Same with relapsed. I think the duration of response is still important in the ESMO guidelines. I think this 36 months are becoming shorter, the interval to say that you can retreat with the same venetoclax-based regimen. But if you progress on a BTK inhibitor, you lost the class of drugs. Unless you get a non-covalent BTK, pirtobrutinib, you have to use a venetoclax-based regimen or idelalisib, which is still available in Europe. quick reference to treatment sequencing or retreatment. I think the main point is if you progress on continuous BTK inhibitor, you lost the class of drug and you have to use either non-covalent or retreat with BCL2 or anti-CD20 antibody, but you can retreat patients with the same schedule of treatment if you use fixed duration schedules. Quick mention of the revenge trial is where a patient that was previously treated with venetoclax-based induction therapy or first-line therapy, retreat if they remain in remission or had progression-free survival of more than a year, receive Ven-G again as a second-line treatment, depending on the duration of the response, determine the duration of the second-line treatment. Is it 12 cycles or actually 24 cycles if it's a shorter duration? And this trial, we're still waiting final results, but good, amazing overall response rates, quoted up to 100% with undetectable MRD rates. That's quite significant. So I think this is just some of the proof that retreatment with some of these trials are effective. And quickly, just to end off is where things are going. I think MRD-directed therapy or response-adapted approaches or personalized therapy in CLL is becoming something that's being investigated. The FLAIR trial didn't start off as this, but the ibrutinib venetoclax arm was added to this trial with MRD assessments, and the duration of therapy was anything between 2 and 6 years. And MRD assessments were done at year 1, 2, and 3. If you achieve the MRD negative state after 1 year, you continue with another year. Sorry, this is depicted better here. If you double the time on therapy as soon as you reach undetectable MRD status. And the main goal was to see if you can potentially cure some patients with CLL. So treatment duration was between 2 and 6 years. Now, median follow-up was 62 months. You can see there was MRD negative states in peripheral blood and bone marrow was the best with a combination of ibrutinib plus venetoclax, and with good progression-free survival and overall survival benefits. Most marked in the unmutated IGHV group, less so in the mutated IGHV group. So I think the higher risk genetic groups will probably benefit the most from an MRD guided approach. And I think something that I think will be quite informative on this topic is the MAGIC trial that completed its recruitment. It enrolled more than 600 patients in a 1-to-1 randomization of acalabrutinib venetoclax combination versus venetoclax obinutuzumab combination. Also MRD guided approach. If MRD assessment, the MRD negative, the treatment is stopped. If not, they continue until 24 months of treatment. And the results are anxiously awaited to see if this will actually have an impact on patients' outcomes. So just to finish off, CLL has got a high heterogeneous clinical course. I think we all know those patients that was diagnosed with CLL, follow them for many decades, and they never progress and never require treatment, compared to those that's diagnosed symptomatic disease and a relapsing remitting course and eventually die of their disease. Remember, we only treat symptomatic patients. Symptomatic disease, high-risk disease in the absence of symptoms. It's not an indication for treatment, and the watchful wait approach is the most appropriate. Remember the prehabilitation if you can. Chemotherapy is largely replaced by novel therapies. Now, unfortunately, these drugs are highly efficacious and effective with manageable toxicity, but unfortunately very costly, and very few patients in our country have access to these drugs at this point in time. Our treatment decision should be patient-centered, and they should be actively involved in the treatment decisions. And there's a general trend in the guidelines away from continuous therapy to more fixed duration therapies due to the benefits that I mentioned before. Future direction, personalized therapy or MRD guided approach might be something that we will look at or will be included in the guidelines in the near future. Thank you.
Thanks so much, Pieter. Really appreciate that. That's great. I already see some comments and questions in the chat, but we will get back to them a little bit later. I want to do the case presentations first. While Zeenat is loading her slides, thanks for a wonderful presentation. That was very clear, very easy to follow, and I think definitely a good starting point for our discussions. So Zeenat, if you want to share your screen, then in the meantime, Pieter, you can throw an eye on the questions in the chat box, and we'll get back to them now. Okay, Zeenat, over to you.
Okay, hi everybody. So I've got 3 very brief case presentations, clinical case presentations. Before I start, that this is my disclaimer, and it is not of the opinion of anybody else. Right, so my patient 1 has the following profile. He is a 68-year-old male. He is a retired teacher, and his only comorbidity was that of controlled hypertension. And his presenting complaints in January 2026, so this was earlier this year, so relatively recent, was that he had fatigue for 6 months, which was quite disabling. He had a significant amount of weight loss. He reported 5 kgs in 1 month, and we know that we look for 10 kgs in the preceding 6. Night sweats and painless neck swelling. He was pale. He had generalized significant lymphadenopathy in multiple lymph node regions and a moderate to massive splenomegaly. And his hemoglobin was 10.5, his platelet count was 130, and he had a white cell count of 45. And this is an image of his peripheral blood smear, which showed smudge cells and the homogeneous, monotonous population of small, round, mature lymphocytes, which you can see, which don't have the arrow on them. So a diagnosis of chronic lymphocytic leukemia was made, and this was confirmed by flow cytometry, looking at the relevant markers that Pieter discussed. The IGHV mutation status was found to be mutated, and this patient had no TP53 mutations. And when discussing his management, despite the fact that he had no mutations and he was not a high risk, but he was extremely symptomatic even at this low white cell count of 45, or lowish white cell count. And we opted to get him a BTK inhibitor, which he self-funded because he didn't want any chemotherapy at that age. He had just retired and he wanted a better quality of life. And so he was taking 100 milligrams twice daily. He was counseled on the following adverse effects to look out for. So headache, diarrhea, infections, bleeding risk, and also concern regarding his hypertension. But currently he has a normal full blood count and white cell count. He experienced no adverse effects. Treatment was well tolerated, and he continues on therapy. Patient profile 2 is Mr. RH. This is a 60-year-old businessman diagnosed with chronic lymphocytic leukemia this is supposed to be June 2025. He had excessive loss of weight and night sweats, again, generalized lymphadenopathy in multiple areas, cervical, axillary, mediastinal, hepatic hilum, and quite large nodes. They're 4 by 3 centimeters. The celiac axis, bilateral common femoral lymph nodes as well. He had no hepatomegaly, but he did have a 15.5 centimeter splenomegaly. And again, his hemoglobin was around 11.9. His platelets were 138, and his white cell count was 68.8. His bone marrow, however, was moderate to markedly hypercellular, owing to a significant patchy infiltration by a population of about 55 to 60% abnormal mature B lymphocytes, which co-express CD20 and CD5. And the IGHV mutation status here was unmutated, and he had a TP53 mutation. So this was what we found on his CT staging. And again, here the patient commenced BTK inhibitor therapy, again at his own expense, because as we can see in the comment section, funding is an issue for the targeted therapy in CLL. This patient had 100 milligrams per RSPD. He's also currently well with no adverse effects and a normal full blood count. Patient profile 3 This was a 62-year-old female, Mrs. HH. She was diagnosed in August of 2020, and her comorbidity was that of multiple sclerosis, on treatment for about 30 years. And the other meds that she was taking at the time of diagnosis was Epitec 100 milligrams, Epileptin 400 milligrams, and Tegretol 100 milligrams daily. And on presentation, she was clinically stage 1. She had very small, non-significant cervical and axillary nodes. And the plan at that stage in 2020, which was 6 years ago, was to monitor her 3-monthly, or should there be any drastic active disease requiring treatment changes. So in November 2021, the patient presented for routine follow-up, and she had a hemoglobin of 12. Her platelets were 115.7 and her white cell count was 20. And she reported having cellulitis, which required hospital admission. On a further follow-up in May 2022, her white cell count had gone to 44. And at this stage, the patient had significant generalized lymphadenopathy and B symptoms, so loss of weight, night sweats, fevers. And in 2022, therapy was attempted with ribomastine or bendamustine and rituximab, but severe infection led to discontinuation of the treatment, and the white cell count seemed to stabilize for a few months thereafter. In June 2023, however, the patient's HB was 7.7. She had a white cell count of 113, and at this stage she was requiring significant transfusions. She was commenced on BTK inhibitor therapy, and her white cell count normalized within 4 months. And she's still on the BTK inhibitor therapy with normal counts and feeling well. And the interesting thing here is that her multiple sclerosis seems to have improved or not progressed. It's quite stable. She's managed to drop the doses of her comorbid therapy. So we're not sure if the BTK inhibitor therapy is actually helping or delaying progression of the multiple sclerosis as well. So these are just 3 basic cases to outline that, as you can see in the new guidelines, that if you can't afford it, or if a patient can afford it, they should ideally be going on to the targeted agents first, and that chemoimmunotherapy is actually in the past. Although we still find that for certain patients we do need to use it. So those are my 3 cases. I think we can take comments at the end after Prof finishes his.
Wonderful. Thanks very much, Zeenat, for those very interesting cases. Definitely discuss at the end. So let me just quickly share my screen as well. All right, I hope everybody can see that. So my the title of my case is Patience as a Therapeutic Strategy. So again, just to say thank you to AstraZeneca for supporting the session, and also to say that all of the opinions here are my own. So I'm going to give you a little bit of a historical overview. We've heard multiple times today that chemoimmunotherapy is no longer the standard of care, with which I certainly agree. But this patient first presented in 2017, so you'll see quite a different story here. So this man, and I'm presenting the case with his permission, presented initially with herpes zoster on the left side of his face. At that time, he already had a almost 2-year history of B symptoms, recurrent infections, and complained of early satiety. He only had very small lymph nodes unilaterally in his inguinal area, but marked splenomegaly. Looking back at his old blood results, he already had a white cell count or a lymphocyte count even more than 100 in 2015 when he went for full blood count for insurance purposes. Clearly, they did not worry about it because nobody said anything. And he's at the time that I saw him, his white cell count was 392, with a lymphocyte count of almost the same. Hemoglobin was 12.8, but trending slowly down over the previous 2 years. Platelet count, borderline. Beta-2 microglobulin was elevated at 5.9. LDH was normal. He had a low IgG level. IgA and M were normal. Classical flow cytometry, CD38, which was quite important to us in those days, or maybe around that time, was low and favorable. So he was staged as a RIDE to BNA with a CLL IPI in retrospect, because we didn't have that at the time, of 3, which would be intermediate. So he basically met, we did not actually meet any treatment criteria. Sorry, that's what it's supposed to say at the time. His IgVH was mutated, which is a good sign, of course. Del13Q is the most favorable cytogenetic category, which he had. CD38, I said, was negative, and there was no TP53 nor any Del17P. So overall, quite a favorable risk profile. And sorry, I must apologize. He did meet criteria for treatment in that he had B symptoms. Sorry. So I decided, despite this favorable prognostic profile, we decided to treat him, and you can see what happened here. So at the time, he was started on chlorambucil, and the blue is the white cell count, and you can just see there historically, before I first saw him in 2017, his white cell count had already increased from about just over 100 to around about 380. His hemoglobin was progressively dropping, and he had B symptoms. And then he was started on chlorambucil, but very rapidly developed a very severe pancytopenia. Neutrophils went down to 0.0, HP to 5.5, platelets to 1. The question, of course, was, is this treatment-related or disease-related? He was even bleeding, needed transfusion, and we repeated the marrow, and it actually showed disease progression. So at the time, gave him then rituximab bendamustine. Didn't feel, with his hypogammaglobulinemia, his recent herpes zoster, and his age over 60, that he was the best candidate for FCR, at least at that point. And we were able to get quite a good hematological response. You can see how the hemoglobin improved. The white cell count came right down, but it did need quite a bit of pegfilgrastim and EPO support. Interestingly, he developed anaphylaxis, and not just a reaction, a clear anaphylaxis with shock and swelling and everything, to rituximab during the start of his 3rd cycle of R-Benda. So we managed that successfully, was admitted to hospital overnight, and after that continued with bendamustine only until he had what was considered to be a best response. So one of the questions, of course, at this point was, what if he needs treatment again in future? We didn't have BTKs back then. What would we do with rituximab? Would it still be available for us? And you'll see why I asked that question. But by this time, he had an HP of 14. And then during the next 3 years of surveillance, you can see that his lymphocytes rose slowly from 8 to 53 to eventually 153, but there was no other treatment indication. We repeated his cytogenetics, still a Del13Q, and did not treat until he developed new B symptoms, mild, night sweats. And at the time, it was again also COVID. And we thought, this is a very difficult time to treat a patient. And it so turned out. At that time, you'll remember that CLL patients had one of the worst prognoses if they got COVID. About a third of patients died. So even though he started progressing at the end of December, we waited until about February 2020 before we started him on treatment. And this time we did start him on oral FC. I did discuss the option of ibrutinib with him at the time, but the decision was to wait, and we waited until, September 2020. And you can see here that after the FC was given, he had a very rapid drop in his white cell count, but very soon after, within a month, had neutropenic fever, was hospitalized, peptide amikacin, and we wanted to escalate him after recovery to inpatient FCR. And this is now where the interesting part comes in. We then referred him to the Professor Johnny Pieter and his team from the Clinical Immunology Division, and they actually desensitized him to rituximab. And this was completely successful, and he was able to get FCR. Now, just to say, it was quite a struggle. HP naders during this time, 4.5 to 5, multiple transfusions, platelets went down very low. And then in December of that year, he actually then developed COVID, superimposed on his treatment. There was no place in ICU, where he was admitted in a private hospital. And we actually had the conversation with him and his wife, because he was oxygen dependent and he was literally moving towards palliative care, but then dramatically survived. So he then recovered, had a gradual count recovery post his FCR and COVID. You can see the lymphocyte trajectory at the bottom, which I'll get to in a moment. Then, just for interest's sake, never forget that even despite having many other reasons for anemia, we then found that he had a high MCV and B12 deficiency, which we treated. He was clinically stable, eventually withdrew the prophylactic antibiotics, followed up in terms of his lymphocytes and clinically, and then in late 2023, his lymphocytes had increased to more than 150 again. He had weight loss, and his spleen was enlarged again. So now, clear relapse, requiring fourth-line therapy with limited options. So we started him on acalabrutinib, 100 milligrams BD in January of 2024. So we expected a redistribution lymphocytosis followed by a progressive decline in his lymphocyte counts over the subsequent weeks to months. What we did not expect was a massive surge of 128 just before he started his acalabrutinib to 501. And here you can see it literally within a month. His lymphocyte count went up from 128 to 501. But we could immediately see that his platelet count started to rise. And I said, let's just hang in there and wait a little bit. Let's continue with treatment. And as you can see, his hemoglobin progressively increased, even though for quite a few months, his lymphocyte count hovered near 500. But platelets improved, hemoglobin improved, and I decided to keep going. I didn't have much else anyway, so we just went on. He was not a candidate for any of the trials we had at the time. And you can now see what has happened over the subsequent 2 years. At the top, you see the lymphocyte count, which progressively came down from 2024 onwards. And just want to show you this. And just to show you what we were faced with, so you can see there at the bottom, the lymphocyte count in red, 128. 2 weeks later, 397. After a month, we are at end of February there, near 500. And it just stays, it hangs in that region. But if you, now just see, at the top, you can see the hematocrit slowly going up during the same time. All right. So, again, why did we persist with this way of treatment? He had favorable biology, no TP53s or DEL13Q at any time. Clinically, he was feeling better. His night sweats improved, his weight stabilized, he started to ride his bike again. Functionally, he was great. Hemoglobin was rising, albeit slowly. Platelets were improving, and we didn't really have any other good options. So just like to share this quote: without seeing the whole picture and without knowing the whole story of a man's life, our judgments about him will most probably be wrong and unfair. And I think the message here is it's very important to see and look at the patient as a whole, not just at the numbers. For example, if you look at this over the 26 months that he's been on acalabrutinib now, where are we now? Literally, he has just gone below his starting lymphocyte count, which was 128 when we started him on treatment at the beginning of 2024, after going up to over 500. His hemoglobin is up to 13.9, platelets up from 59 to 180, CRP remains low, and as you can see, a very, very interesting 26 months where we've not seen a fantastic change compared to baseline in lymphocytes, but in every other respect, the patient is doing great and is actually very functional and still on treatment. So where are we today? He's now 70 years old. He was 62 at the beginning. He's been on acalabrutinib for more than 2 years. His hemoglobin is normal, his platelet count is normal, his lymphocyte count continues to decline. No B symptoms, cycles regularly. He does have ongoing immune suppression with hypogammaglobulinemia. He was admitted in February for pneumonia, which has recovered. Struggles with chronic sinusitis. He's just had sinus surgery with partial response, and he's also getting some symptomatic treatment. So we're struggling more with infections now, and ideally I would have liked to give him IVIG, but as you all are very aware, despite the patient having severe hypogammaglobulinemia, as you can see in the bottom box, our dear medical aides would not pay for this unless the patient has had multiple hospital admissions for infections, of which he only had one in the last 2.5 years. So we can summarize and say, at least from my experience here, that the lymphocyte kinetics on BTK inhibitors can be much slower than what we used to from the publications. Is it due to the fact that this patient's more heavily pretreated, multiply relapsed? I don't know. Clinical response and looking at the other counts, hemoglobin and platelets, may be more reliable as a signal for response, not just lymphocyte counts that go up. I think favorable biology certainly played a role here in reassuring me. Rituximab anaphylaxis does not preclude future use, and there are desensitization protocols that can unlock treatments that you would otherwise think that would be unavailable. And actually, for many treatments in general, we found that if you have a good immunologist, they can do wonders to get a patient desensitized. So in a resource-constrained setting where the patients don't necessarily have other treatment options, informed persistence might be the best therapeutic strategy. And I want to thank and acknowledge Prof. Pieter, who's done the desensitization for us, Prof. Darlene Libber, who's helping us with his sinusitis management, and the patient who gave me permission to present his case. So with that, I think the conversation can be opened, and let's start at the top. And I'm going to start, maybe Pieter, you want to take the first couple of questions. Jacques asks, is there not recent data showing that the atrial fibrillation and hypertension is a class effect? And if dose adjustments are done for ibrutinib, the incidence is very much the same as for the other BTKs.
It could be. It is definitely a class effect. Yeah, so it might be, I'm not aware of that publication. In the treatment guidelines, it's clearly mentioned that ibrutinib cannot be recommended any longer if there's a second generation BTKs available. So yeah, I don't think it's generally not recommended in the guidelines to use ibrutinib. I think the preferred drug is acalabrutinib and zanubrutinib.
And then from Moses, for some of us who work in resource-constrained settings, is there any data? And Moses, I want to reassure you, we all work in those settings generally, although I understand where you're coming from. Some of us are more resource-constrained than others. Is there any data, even observational from your clinics, of using either monotherapy, low-dose venetoclax, plus or minus rituximab versus chlorambucil or bendamustine plus rituximab in first-line treatment for older patients with CLL? I certainly don't have any experience with venetoclax first-line only in elderly patients. I do have quite a bit of experience with the other drugs, the more traditional chemoimmunotherapies in that older patient group, often very, very successful. Although chlorambucil is definitely not a preferred drug these days, it can still be an option if you've tried everything else and it didn't work, but it's not the best. Don't know if anybody else has got other comments. Pieter, Zeenat?
So, yeah, I think we still find ourselves using some chlorambucil, especially for our elderly patients who have multiple other comorbidities and can't make clinic appointments or can't check bloods regularly. And, the numbers sort of affect them. They're having a white cell count of 200. Psychologically, it does not sit with, they want to have a normal white cell count. They want to have a normal lymphocyte count. So we have a few patients who we still have on chlorambucil because they cannot afford the BTKs, they cannot afford, gap covers and top tier plans, etc. But just a handful of them, and it still serves its purpose. It normalizes that white cell. We've got patients in their 90s, 92, 94, in retirement homes or frail care centers, and we get the labs to go out and bleed them monthly or 6 weekly and just make sure that nothing is untoward. But we still find that there is a place for chlorambucil.
Yeah, and I think in public sector, certainly we use chlorambucil still because our options are limited. I think the most important part is, getting the patient on something, whatever you have, and chlorambucil should certainly be part of that armamentarium, and especially in the elderly, often very good. I like the continuous dose adjusted to neutrophil count, works very nicely. I used to use the pulsing a lot, but the continuous dose works quite nicely, I find. Anyways, Jark again. Thanks, Jark. You're very active today. Love it. Does the guideline still recommend continuous therapy for TP53 mutated or DEL17 disease? Although the data is probably limited, I know most experts preferred this when last I looked.
I can answer that. Yeah, so the guidelines, especially the British and the ESMO guidelines, definitely do prefer BTK inhibitors monotherapy continuous as first-line treatment or treatment for in the setting of a TP53 mutated disease. I think many speakers will call it a BTK-based therapy because of the even if you combine it. So the guidelines will say that if, for instance, you can't use it, the other things that's mentioned, or what is also mentioned, that there's no data directly comparing VO or venetoclax ibrutinib at this point yet. I think this CLL17 data is too immature and there's too small. It's a small group of people with the TP53 aberrations, but although the progression-free survival will probably be shorter, you can probably retreat those with the same treatment. So we don't know what the long-term effect will be if you retreat with fixed duration compared to continuous therapy. The jury is still out there. There they mentioned venetoclax as a single or monotherapy as a continuous therapy as an alternative to a BTK monotherapy if there's intolerance to a BTK. But yeah, that's pretty much the guidelines still favor, it seems like, BTKs. NCCN didn't really favor anything. They actually said both preferred BCL2 containing regimens and continuous BTK. Both equal options, it seems like.
Thank you, Pieter. Cecile says, sadly, for state sector patients, clinical trials remain the only way to access any modern treatment for CLL. Absolutely. And again, a reminder to everybody, there are multiple clinical trials running in South Africa. Many of us have taken part in the Amplified trial. We currently have a couple of 3 nemtabrutinib trials. The relapse refractory one will open again soon, hopefully in June, July. The other first-line trials, there's a nemtabrutinib venetoclax trial that is currently open as well. So certainly something to consider. And I think many sites around the country are running those. Maybe those who are can put it in the chat so that those who want to contact you for their region can be aware. Right, Fiona, you can maybe put something in there for us. Then Jark says, I've seen quite a few patients with very high white cell counts developing very rapid and deep pancytopenia with initiation of chlorambucil. Yeah, and I wonder if that's related to the very poor bone marrow reserve, Jark. I'm sure that might be part of it. Also interesting with my patient, initially, after starting the chlorambucil, the first 2 weeks, there was a massive increase in his lymphocyte count back then on chlorambucil, after which it started to drop. So I thought, okay, we're going in the right direction, but not too long after, deep pancytopenia with very poor reserve on bone marrow. Did you consider Ritax desensitization? So Jark preempted that, and he actually refers us to the protocol on up to date. So there is it. And then Jark has got a patient currently on zanubrutinib, TP53 mutated, who had a rise in white cell count to 200 at the start from around 90 after 10 months, still not normal, around 50, but clinically doing extremely well. Wanted to ask how often colleagues have seen this very slow decline after initial rise. At least I know one other colleague. There we go, Jark. 2 of us. I'm sure there might be others as well. Okay, so one could really argue PMB for the IVIG. If that patient was in state, he would have received IVIG. It's on the EML. If confirmed recurrent infections in this setting. Thanks for that, Jark. That's a very important point. Okay, right. If anybody wants to speak up and perhaps ask a question, you're also or make a comment.
Say something on that, the rise and the fall. Firstly, thank you to all the speakers. Excellent, excellent presentation, walking us through the whole story, really, and then into the modern era. It's very distressing that the medical aids are so out of step and the public health care service is so out of step with the modern treatments. I think these are, yeah, I mean, there's a clear advantage to these new treatments. They're just absolutely in a different league. And even old dinosaurs like me who hang on to old things just want to say, why? You know, this is just, I mean, we're still fighting for bendamustine, you know, and this is, you know, these are just streets ahead. So these are fantastic drugs and we really want to use them, and they have their places in various ways. I do question the combination of IV. I understand the medical aids won't pay for it, and I think the advantage is very limited there. Immunoglobulin therapy, I think, and infectious management is very important. But it's a class effect of the Bruton kinase inhibitors, especially in people with bulky disease or a long history of disease, is that you first get mobilization out of the lymph node and marrow population, and the white cell count goes up. And it's very distressing for the patient and for the doctor too, if they're not expecting it. And it does usually settle down in a much shorter period of time than your patient, Vernon. But I've also had an old patient who'd had like 20 years of different treatments who had that like sort of 2.5 years before they got down into the sub 20 levels. But again, thank you very much, everybody. That was fantastic. Really good talks.
Wonderful. Thanks, David. Now, I think it's certainly been our experience on the trials where we've now been working with most of these BTKs, that there is this redistribution lymphocytosis in the beginning. I think what was very unusual for me is to see this protracted lymphocytosis, but with everything else improving, which was an eye-opener. So certainly a learning for me.
But those patients get what your patient had, although he got it earlier, but shingles and, bad COVID. And I mean, this combination of disease and drug is it's very common, those infections. And the other thing that's important is they get skin squams, particularly the men, and you need to address them aggressively early, because otherwise they end up looking like, almost patchwork quilt with all the skin grafts and stuff.
Sorry, what did you say? They get skin what?
No, they get squamous skin.
Oh, yes.
Yeah, it's
Absolutely.
very well described, but
Yeah.
just to highlight it, that we must address it aggressively and early, especially in our South African sun, and it seems to be mostly the men and old white men, obviously. So maybe I have a personal interest there.
No, David, I'm so glad you mentioned that. It's something that we've recognized to the extent that I hardly have any Caucasian patient with CLL that does not develop a skin cancer or had one even before they first came to me. So all as a standard, every single CLL patient has to see a dermatologist once a year. It's really, really, thank you for that. We actually noticed that in the Free State and wanted to do a study on it. And then the Australians were ahead of us and they published exactly that. So it's a very good comment. All right. So I think we can move to a close. I just want to quickly say one or two important things here. Number one, we are living in the most exciting time ever for CLL. We were fortunate to move through the CML era, at least some of us like me and David and a few others that were there before we had any TKIs and still treated CML with hydroxyurea and interferon and cytarabine and all those things. I'm sure Cecile and Estelle and some others here will remember. So now we're living in this equivalent with CLL, which is just fantastic. And the fact that we've got so many options in such short succession is just beautiful. And with what we're seeing in the clinical trials, I can tell you more options are coming and the future looks bright. We only hope that the affordability will improve for patients. And I'm sure it will, especially if we work on with fixed duration therapies, it's definitely going to be better. The next thing I want to mention again is that we are going to be writing, hopefully by the end of this year, new CLL guidelines for South Africa. And if any of you are willing to put in the hard work, shoulder to the wheel, join us, we'd love to have you. Everybody that works with us will be co-authors. We would really like to have broad representation, and you can just contact me and let me know if you want to take part. We're already quite a bit down the way, and we've got good support for that. Same with paroxysmal nocturnal hemoglobinuria. That's the very same thing. We'll be writing 2 sets of guidelines, at least on those 2 topics that I'm driving. I know there are others who are doing other things. Again, a big thank you to AstraZeneca for sponsoring today's session, to Blood SA for all the wonderful organization behind the scenes, for those who came late. All the videos are on the website under resources, Blood SA website, go and have a look. And finally, thank you to Pieter, to Zeenat, to all of you who attended. Thank you for the wonderful talks. Thank you for everyone who contributed and commented. Really fantastic. We look forward to seeing you here next week with Prof. Adam Bagg speaking about Castleman's disease, and you will not regret it. Please come. All the best and bye-bye.